Okay, good afternoon, everyone. So it's a packed room, so it means that the topic that we're going to tackle today is of importance. So thank you for being here. So it's a TNT sponsored by Medtronic about valve performance, durability, and how the choice of the first valve may impact the outcome for the patient. So let me start by introducing the team. So you all know Mohamed Abdelwahab, who's going to moderate the session with me. And as discussant, you see these faces that you all know. So feel free to interact with them, to ask them anything that you have in mind. So we have Gilbert Tang, Ole de Bakker, Mike Reardon, Tanya, Rudolph, and Nico van Migem. So a team of friends just to try to help us understand how the choice of the first valve may impact the final outcome for the patient, and how important it is when it comes to the index procedure. We're going to try to all learn together what are the latest data on the self-expanding supra-annular platform, because there have been very important data when coming to the durability and the hemodynamic performance of this platform. And at last, we will try to understand how the new iteration of that platform, the FX, may impact our procedural outcomes for the benefits of the patient and the long-term outcomes from the patient. So having said that, Mo, maybe we can say a couple of words on the how to address, to populate, come up with questions and comments through the chat.
Yes, so I'm sure most of you will be interested in interacting, giving us also some thoughts, ideas. I mean, it's an important decision-making process when it comes to the first valve you are implanting in a patient. And it's also a topic that is hot and can lead to a lot of controversial discussions. So interact with us. You have more than one option. There are a lot of microphones here that you can come directly and ask your questions. And you can also interact with the app, and then we'll make sure that we give you an answer to your questions. And maybe I'd like to stimulate a little bit the discussion. We have one polling question that we want to start with.
Could we see the poll? So what we want is for you to reflect on what is the most important consideration for Tavi, to your opinion, according to your own practice. Is it durability? Is it hemodynamics, the valve performance? Is it coronary access? Is it pacemaker? Please use your app. There is the QR code, and then vote for that poll. And we will see at the end of the session what is the outcome and what is relevant to you for your daily practice. Okay, so having said that, maybe we can start the discussion. And I would like to start with the ladies first, and that's I think a very important consideration, because we're going to we are talking about patients with longer life expectancy, Tanya. And these patients with longer life expectancy may be different between 70 and 85. Do you have the same consideration when it comes to the valve selection when you are dealing with a 70 years old patient or 85 years old in your daily practice?
Well, I think per se the durability is important in all the patients, no matter if they are 70 or 80 plus. But of course, it matters more in the younger patient. And I think also the coronary access is something in my mind which is really important, in particular if patients already have coronary artery disease at the time when we implant a Tavi device.
So that's so durability. That was the first thing that you consider. And what would be an acceptable durability for you for a Tavi platform?
Well, I think we have the data from the surgical valves, and so the best valves have durability of 10 to 15 years. And I think this is something which I would also ask for a Tavi platform I can rely on in younger patients.
And do you agree on that, Mike? You are the surgeon here, so.
Well, the answer is yes, but you have to know how old they are when you put in your valve. The older you are, the longer the valve lasts. So, you know, a valve that lasts 10 years in a 60-year-old may last 20 years in an 80, 85-year-old. And durability and hemodynamics are really tied together. Good hemodynamics go with good durability. So those are actually one and the same.
Okay. So durability, we heard durability, 10 years, and we have the privilege of having you, Ole. There is the Notion data. Would you drive us through what are the main learnings from the Notion trial?
I think we will discuss it maybe even later in more detail, but I think first of all, what is obvious is that, first of all, if you talk about the long-term durability, really, that the signal we have that the Tavi valves, that was all done, the Notion with the core valve platform, by the way, not with the current Evolut, that these durability data are at least as good as the surgical group. And there's even signals that it's the severe structural valve deterioration, the severe biprosthetic valve dysfunction, patient prosthesis mismatch is better, lower in the Tavi arm as compared to the surgical arm. Whether this then translates into clinical differences in outcomes. In the Notion trial, there's no difference in the clinical outcomes in real hard endpoints, mortality, stroke, and myocardial infarction. But I think there's on the other hand, some great data from the pooled data set from core valve Evolut from the high and the lower, high and intermediate risk patient group that shows that patients which have biprosthetic valve dysfunction, that there is a 1.5 to 2% hazard ratio of higher risk for mortality, heart failure, valve-related hospitalization, etc. So this has a clinical consequence for your patients.
So I heard that patient prosthesis mismatch could have an impact. And if we're dealing with younger patients, longer life expectancy, quality of life or exertional capacities was one thing to consider. Do you think that that severe PPM is meaningful? Is it a meaningful consideration that we...
I do think so. I mean, if we talk about, that's typically the discussion we have, yes? If we talk about PPM, it's always, people think always, oh, this is about the durability, the long-term durability. I see this also differently. I think it's also if you treat these younger patients, as we sometimes do already in Copenhagen, these group of 70, 75-year-olds, well, these patients are still very active. I mean, they go mountain biking or cycling with their friends, or if you give them a valve which ends up with moderate or severe PPM, you will limit their exercise tolerance and capacity. So I think that PPM is not only something it's far away in the future, it's important. No, it's actually also important for this patient right now.
So durability, maybe around 10 years, but as well as hemodynamics and PPM being one part of the equation. I guess you have a couple of slides that you want to get more in depth.
Yeah, well, this is then indeed first about the data shown actually very nicely at TCT by Michael Reardon. And what is the evidence in low surgical risk populations? This was the data from the 4-year data follow-up of the Evolut low-risk trial. We know all the data about up to 1 and 2 years. As you see the curve there, there was a small difference between the Tavi and the surgical arm, between the Evolut in the low-risk population and the surgical in the low-risk. This is the primary endpoint, all-cause mortality and disabling stroke. So very hard endpoints. At 1 year, 2 year, there was no statistical significance, but you see that there's a diverging of the curves, and this is now a 26% relative risk reduction from 14% in the surgical arm versus 10.7 in the Tavi arm. And if we go to the next slide, this is the endpoint all-cause mortality, disabling stroke, or heart failure or valve-related rehospitalization. So really clinically important and significant for your patients. You see here with a p-value of 0.04 and a 22% relative risk reduction, there is statistical significance. So they get statistical significance and smallly diverging curves up to 4 years. So extremely promising data, I would say, in this low-risk population. If you then look to the hemodynamics, not a surprise, hemodynamically, Evolut platform outperforming the surgical valves, and very important, it maintains this superiority, or it maintains this extreme good performance up to 4 years. No signal whatsoever of early degeneration. And then I highlighted this as the last thing. I think something which we don't talk a lot about, but I think we should maybe, is that we take it for granted that clinical valve thrombosis is 0 or 1%, but that may be valve specific. Yes, and we can discuss this later.
So thank you, Ole. We come back to this issue of valve thrombosis later on. So we're saying that so what we want for our patients, or younger patients, is a valve that is durable, low gradients, better hemodynamics, and very promising data that Mike has presented at TCT. But what is a patient with longer life expectancy? Is there a cutoff? I'm once again going to ask you that, Tanya. Is there a cutoff in your practice for considering the patients as being young? Mike has an answer to that. But you, what would you advocate? Is it 65, 70, 75? What is young, according to your practice?
Well, I think the problem is that there is no clear answer to your question, because I think it's relative. I mean, there might be a patient being 65 who is still young, and there might be another one being 65 and he's not young anymore. So I think it comes to comorbidities, to active lifestyle. And I think this is also the drawback when we look at the guidelines, at the ESC, EICTS guidelines, that we really have this clear cutoff of 75 years, which defines somehow an older or maybe a younger patient. So I think we always have to take into account the life expectancy of the patient, but also, as I said, the comorbidities and the active lifestyle.
And so you said the age is something, and Ole, there are very important data coming from the Nordic community. If you are 75, what is the average life expectancy, the remaining years that you have?
Yeah, that's a very good point I think you make there. I think we all think of, well, if we have an 80-year-old patient coming to us with severe aortic stenosis, his average life expectancy is around 8 years typically. That's we know from based on Swedish large data set, registry set. If, on the other hand, a 75-year-old comes to us and he presents with severe aortic stenosis, the average lifetime expected life expectancy will be around 10 years. Yes, so and then if it's a 70-year-old, we think that almost every patient becomes 90, but that's not the case. I mean, these patients presenting at 70 years old with severe aortic stenosis, they for sure have diastolic dysfunction, they have some heart failure underlying. Their expected life expectancy is 12 to 13 years. So this is, if we can give this patient, in theory, a valve. What I want to do as an operator is give a patient a valve that outlives the patient, not the other way around, that the patient outlives the valve, because then he has to undergo a re-intervention, you may run into a lot of complexities. So that's the ideal, and I think you can do this even up to that 70-year-old patient. If you have these valves which have to have a durability up to 10 to 15 years, I think you're good.
Okay. Thank you. That was these are very important considerations, because it's not only about the durability of the valve, it's combining it with the life expectancy of the patient, and that's very important. So Tanya, would you summarize what the guidelines tell us about them?
Yeah, I think you see here from the scheme, from the guidelines, from the European guidelines, that if we have a patient who is under the age of 75 and actually is at low risk according to the Euroscore or STS guideline, and this patient is definitely operable, then you should go for an aortic valve replacement, so a surgical one. And on the other hand, the guidelines tell us if you have a patient of an age older than 75 and he's suitable for transfemoral Tavi, then you should go for the Tavi implantation. And we all know, I think, from our daily clinical practice that there is a wide range of patients in between here. So we have patients who are older than 75, but they are not suitable for a transfemoral Tavi, or maybe they have a highly calcified valve, not being suitable for any, or not a good candidate for being implanting a Tavi device. And then, of course, we also have patients here in between who are younger but are at intermediate or high risk, and they might qualify for either one. And I think here the heart team has an important role to choose really the right option for every single patient.
So thank you for this clear description. So we see that here more in Europe it's 75. Mike, who would be a young patient according to your practice?
5 years older than me down, which makes it 75.
So 55?
Yeah, 65 is a very young patient. So the U.S. guidelines, of course, 65 or younger are going to live 20 years or more. Still surgery, 80, 10 years or less, TAVR in between, physiologic risk of surgery, anatomic risk of TAVR, and what the patients want. But I think it's very important to look at the fact that not all 65 and 70-year-olds are the same. There are some that we'd look at and I wouldn't even operate on them, and there's others that are still out running marathons. And I think that it's the life expectancy that is most important. I think the Sweetheart study really helped us out there in looking at both high, intermediate, and low-risk patients. The high-risk patients, none of them made a 10-year average lifespan.
Exactly.
Intermediate, they barely touched it, and only the low-risk went significantly above that. So I think that, I think that somewhere between 65 and 75 is the right landing zone. I think 75 is a little high, but we'll see as the data comes out.
Thank you, Mike.
I mean, if you look deeply into the guidelines, these age cutoffs have been probably mainly defined because of considerations about durability, like the expectations that the durability of THVs may be less than those of surgical valves. But Nicholas, we now know from, I think, a couple of good trials that this is probably not true, correct?
What is not true?
That surgical valves have better durability than transcatheter valves.
I think it's complete nonsense. I think as a matter of fact, I think that the historical surgical literature is relatively poor in terms of knowledge about long-term durability. I think we have now data, enough sample size from randomized control data comparing Tavi with surgery out to 5 years that lets us at least say something about what is happening with these valves out to 5 years. We won't have enough time to give a good opinion on durability because 5 years is not long enough. We already know that we need to go beyond 10 years to give a meaningful answer to the durability question. But we do get a hint. And that is when you look at bioprosthetic valve dysfunction. And so you will get granular information on that. And that is something that I can demonstrate in a second.
Yeah, Nicholas, I do think it's important that we look at the fact that all surgical valves don't fail at the same rate. When we say valve failure, it is not a class effect. Every valve fails at a different rate. And every new surgical valve comes out with no data. Every surgeon rushes to put in that valve. So I think we need to bear in mind that we don't seem to look at this the same way from two different fields.
Well, we may have the same story in the transcatheter space. I think we have some indications that one of the valves that is no longer on the market also has a tendency to degenerate faster than others. And we don't know the exact answer in terms of comparing balloon expandable with self-expanding valves at this point in time, but potentially we will down the stretch.
So give us like a glimpse into the data you just mentioned on the comparison between surgery and transcatheter valves, at least for the self-expanding valve.
All right. So what I'm going to do is I want to show you some data from a pooled analysis from 2 randomized controlled trials, the intermediate risk through Tavi trial and the Evolut or the core valve high risk trial. Both randomized controlled studies, high risk, intermediate, Evolut or core valve versus surgery. And what you can see if you look at bioprosthetic valve dysfunction, so we're not talking about durability, we're going a little bit more deeper. What can go wrong with a valve? Well, either there is endocarditis, there is thrombosis, or there is a structural or a non-structural valve degeneration. And this is an important separation of things that can happen to a valve. For instance, if we talk about non-structural valve degeneration, basically you did something wrong as an operator, as a surgeon or interventionalist, because we're talking about paravalvular leaks and we're talking about patient prosthesis mismatch. Those are the quintessential entities of non-structural valve degeneration. But basically the patient leaves the lab or leaves the OR with non-structural valve degeneration. So that is not, at least in my opinion, of interest in the discussion of durability. We want to see what is changing over time. And then it is interesting. You see in orange the surgical reality, in blue the reality with core valve Evolut. And then in terms of bioprosthetic valve dysfunction, we can now say out to 5 years that Tavi with this supra-annular functioning valve outperforms surgery. This is really astonishing. But then you want to know, okay, you talked about bioprosthetic valve dysfunction, but there are these entities. Well, let's look at the entities. And you might think from back in the early years, yeah, we know that there will be paravalvular leak with Tavi, and there will be patient prosthesis mismatch with surgery. Well, we see that. We see more non-structural valve degeneration with surgery, 8% versus 3%. We see no difference in terms of thrombosis or endocarditis. I think the main takeaway and the novelty from the last year of research is that you also have more structural valve degeneration with surgery. And this may be predicting what's going to happen in terms of durability. And we are hypothesizing here, this is, we're thinking out of the box, but if at 5 years a surgical valve degenerates more than a transcatheter valve, well, what would that resonate in terms of durability? I think if I would have to bet on it, and my dad always told me, you are never supposed to bet, never do that, so I'm not going to do it. But my guess is that Tavi may have superior durability even today as compared to surgery.
Yes, so these are very important and also very interesting data. These data come from the high-risk US trial and from Tavi, so high-risk, intermediate-risk trials. And we all know that these patients, they do not probably, they will not probably, the majority of them will not survive to 10 years. So it will be probably very difficult to draw meaningful conclusions on 10-year data from these trials. But on the other hand, we have the Notion trial, which included a little bit younger patients, low-risk patients, and there are 10 years data out that you want to comment on, Ole, a little bit more in details. You mentioned them. Yeah. I guess some details are important here.
Indeed, they were not really younger, Mohamed. They were actually relatively old. I think the average age was around 78, 79. So they were not really younger, but they were low risk. And that's the reason. So they were low risk, as you see. And that's the reason why even up to 10 years follow-up, there was 35 to 40% of patients still alive. And that's the unique thing. So these patients, remember, these were patients treated in the period 2009 to 2013. These patients were randomized in that period. In that period, most centers, most countries, they were talking about considering doing Tavi in high-risk patients. So there were people before me, they were very visionary in that sense that they were pushing this into low-risk patients, and that gives us the opportunity to have a good pool of patients still alive at 10 years. So you see clinical endpoints, all-cause mortality or all-cause mortality, stroke or myocardial infarction, the primary endpoint, they're really on top of each other. Tavi with core valve versus the surgical arms. But then it's going to be interesting if we deep dive into these data. So that's the SVD, the structural valve deterioration, as Nicolas mentioned. On the left-hand side, so that's moderate or more than that, moderate or severe. We see 21% in the surgical arm versus 15% in the Tavi arm. Of course, this is a relative risk reduction, again, of around 25%, so that's a little bit the same as we see in the low-risk Evolut trial shown at TCT. Of course, there's no statistical significance because, of course, this study was not designed and powered to show statistical significance at 10 years. But on the other hand, very interesting, I think, if you look to severe structural valve deterioration, and you can see the definition below. What is severe structural valve deterioration? That means there is a mean gradient of 30 millimeters mercury or more, and there is an increase in the mean gradient of more than 20 millimeters mercury. Or there's a severe intraprostatic AR, which doesn't appear. So if we have that definition, which is really clinically relevant for your patient, you see this was only 1.5%, so virtually non-existing in the Tavi core valve arm versus 10% in the surgical arm. And there I fully agree with Nicolas. I think there is a clear signal, and this was statistically significant, there's a clear signal that these valves, these Tavi valves, they last up to 10 years excellently. And there is more, up to 10% in the surgical. But this is, of course, a pool of different surgical valves. I fully agree, and I admit that. But that's, on the other hand, some surgeons say, yeah, these are valves which are maybe not implanted anymore. On the other hand, core valve is also not implanted anymore. Yes. Then if we look to severe bioprosthetic valve dysfunction, again, Nicolas mentioned and explained very nicely this contains severe SVD, but also the severe non-SVD. And there you see a high percentage of patient prosthesis mismatch in this cohort, in the surgical arm. And then again, clinical valve thrombosis 0, endocarditis up to 10 years, no difference whatsoever between the two groups. But again, you see a clear difference in severe bioprosthetic valve dysfunction, which has clinical significance for your patients. And then if the last result, bioprosthetic valve failure. So there's a lot of definitions I'll throw here to you, but it's interesting that and important that you try to understand these. This is the bioprosthetic valve failure. For me, the most important in there is to look to the rate of re-intervention, because that's really important for your patient wants to know what's my risk I have to be re-intervened on. You see this was totally no difference for between 2 and 4% in both arms. So my conclusion from the 10-year Notion data, which is a unique pool of data, think in older patients with low risk up to 10 years, there is a similar risk of all-cause mortality, stroke and myocardial infarction. There's a lower risk of the severe structural valve deterioration and the severe bioprosthetic valve dysfunction after TAVI as compared to surgery. And there's a similar risk of the BVF, or that's kind of a way to say there's the same risk of re-intervention. Yes?
Yeah, so I think, I mean, we have now a couple of randomized trials, and all of them are pointing in the same direction, using the self-expanding device in one arm and using like multiple surgical valves in the other arm. And this is actually one point that is being criticized by the surgical community or some of the surgeons. One of them is in the room, and he's not advocating us to compare apples and oranges. How would you respond to this, Gilbert? Like, I mean, the types of surgical valves that have been implanted in the control arms are variable, correct?
Yeah, I mean, to Mike's point about, different surgical valves perform differently, and we know that. And also different TAVI valve may perform differently as well. But, the trial is trial. You have to look at what's realistic. And that's what surgeons prefer. If I, surgeon A, prefer one valve, we're going to put in that valve because we believe we'll give the patients benefit, versus Mike may want to implant a different surgical valve. You can't force an implanter to put a valve that they don't, want to put in because that jeopardizes the patient. So I think you have to be realistic and be real world in some way. So.
Mike,
I will say that of course, since I ran the trial, I got those complaints, and there were complaints like, well, you used too many trifectas. Well, you really don't expect trifecta to affect anything at 4 years, and I actually ran the endpoints for trifecta and Carpentier-Edwards, which is most common, and there's no difference. I heard you used too many mitral flows. Well, we only used 5 in the entire trial. So these are really very comparable valves between the two trials. What's different is the patient populations.
Okay, great. So I think the team in St. Thomas will be ready in a few minutes. So let's present the key data of the patient that we're going to see being treated today. So it's obviously a case with an Evolut FX. You can see here this is a 76-year-old male patient who has severe symptomatic AS. He's independent and active without reduced exercise. With now reducing exercise capacity because of his symptoms. It's quite unusual to see the cardinal symptoms of severe AS, all the 3 of them present in one patient, but this is actually the case here. This patient has dyspnea, angina, and exertional presyncope, so all 3 cardinal symptoms of AS. Prior clinical history is relevant for previous ablation for atrial fibrillation, gout. The patient had a history of a fall in 2022. Not quite sure whether this is related to the presyncopal attacks, was associated with multiple rib fractures and spinal C2 fracture. And you can see here that he's like of an average height and weight. His lab is largely unremarkable, so normal hemoglobin platelet levels, more or less normal kidney functions, and his ECG shows normal sinus rhythm. This is a coronary angiogram, and we can debate on the fact whether we should be using or doing a coronary angiogram before doing the CT or not, but this is the practice is different in different settings. And you can see here, and this is also important in the setting of discussing the type of procedure and the type of the valve that we're going to implant, he has mild coronary artery disease. His echocardiogram, as you can see here, shows a clear, heavily calcified tri-leaflet aortic valve with a high mean gradient of 60 and an aortic valve area of 0.8, preserved systolic LV function, and also preserved RV size and systolic function. I'll hand over to Gilbert, showing you the details of the pre-procedural CT, and then we'll come back to the actual plan and then move to St. Thomas as soon as we can.
Thanks very much, Mohammed. Thank you for inviting me to be here. So I'm going to show you the CT scan that I analyzed ahead of time. So you can see this is a relatively large annulus. The average diameter you can see is around 26, a little over 26 millimeters. Area is around 541 millimeters square with a perimeter of 83.2. You also notice that actually there's 2 chunks of calcium at the annulus. And when you go down to the LVOT, around 5 millimeter cut, it's a little bit smaller, but pretty cylindrical in terms of tubular, in terms of the LVOT versus the annulus, with a average diameter also around 26 millimeter at a perimeter of 82.6. Now, I always do a 1 millimeter slice on these anatomy because you want to look at the aortic valve morphology. It's not just the annulus, it's not like a one-dimensional, two-dimensional, because the aortic root is a three-dimensional construct. So you can see clearly these two annular calcium extends to above the base of the right coronary cuts and also part of between the left and the right coronary cuts. You can see as you go up to aortic root complex, you can see this is a free leaflet valve. You can see the commissures open very nicely, and you can see it's heavily calcified as well. All the way, we typically scan up to the 10 millimeter mark, at least in our center. You can also see the STJ here. The average diameter is 32. It's pretty much a circular shape, and also the sinuses are very generous. You can see the left sinus is 38 millimeters, the right sinus is 37, and the non-sinus is around 38.7 millimeters. Now, one of the important aspects of looking at aortic root complex is look at the coronary height, but also look at the morphology. You can see here the left main coronary height is almost 20 millimeters, so this is certainly a large aortic root. You can see also the right coronary height is around 20.7 millimeters, and you can see the sinus height is 27 millimeters on the left and around 26 millimeters on the right. And you can see here, I just want to show you, this is important in terms of the concept of commissure alignment. So at our center, at least I think routinely, we look at where the coronary takeoffs are. Are they at the center of the sinus, or are they actually eccentrically displaced? And this particular patient, you can see the left main is here. This is the sinus cutoff, and you can see the right coronary is also here. So both coronary takeoffs are actually quite symmetric at the center. And you can see here a hockey puck view, similar to a surgeon's view, having a free leaflet, carefully calcified tri-leaflet valve. These are the CT reconstructed three-cuts view. You can see the LAO 18 and cranial 13, quite favorable. And when you have the cuts overlap view, the RAO 10, caudal 19, so also quite favorable in terms of a self-expanding Evolut valve deployment. We also do an estimate of a septal length. I think the reason being is it's important, especially younger patients, looking at target implant depth, number one, to avoid new conduction abnormality, and number two, can you implant potential valve a little bit shallower or deeper to facilitate lifetime management? You can see this is quite healthy of a 6.3 millimeter septal length, at least based on this current estimate. Now, access is, of course, important. You want to have safe transfemoral access. That's how the trials and the low-risk trials compare. They're not talking about alternative access. You can see this is very generous access, mild tortuosity in terms of the external iliac, but I don't think anything that would be prohibitive. We also routinely look at the arch anatomy, not just in terms of angulation, but also in terms of tortuosity. And finally, we do offer cerebral embolic protection to our patients. So you also want to make sure the arch vessel anatomy are also favorable as well. So I think in summary, Mohammed, you want to?
Yeah, so in summary, as you can see here, a patient that is clearly a low-risk patient. He's 76 years. The heart team discussion at St. Thomas, and I think we might all agree on that this patient is suitable for both surgical and transcatheter valve replacement. The patient expressed preference for Tavi, and this is why the team is currently planning a transfemoral Tavi procedure within 34 millimeter Evolut FX valve. Maybe for you guys who are not familiar with FX, it has been launched in Europe after CE mark early October. It has been FDA approved a few years ago, so we now have it in Europe. The valve itself did not change, but the changes are mainly related to the catheter and subtle changes on the stent frame. You can see here that the tip has been redesigned. It's more like a dilator now to allow easy vessel access. The capsule has been made more flexible, and I think, in my opinion, one of the most important changes is that the shaft has now only a single spine to improve shaft flexibility and deliverability, so it probably will enhance or improve and increase the type of patients that we can treat with this device. There's an optimization of the stability layer, and you will see some data on that at a later time point that may help us implant this valve in a more symmetrical way. And when it comes to lifetime management, we have now enhanced visualization of the commissural site, at least. There are 3 dots, gold markers on the inflow portion of the valve. They help you to ascertain the depth of implantation because they are located at exactly 3 millimeters. And on the other hand, as mentioned, they mark for you the commissures, which are seated, of course, higher up, in order for you to make commissural alignment, at least fluoroscopically, easier.
So yeah, the team is ready in the cath lab. So I may just ask one question to you, Nicolas. In fact, it's 2 questions within one. The first one is that this is a kind of gray zone patient in terms of sizing, 26. Do you consider the 34 as the team is going to operate to do it in London, or would you go for a 29? That's the first question for the audience. How do you do in tricuspid patients? And the second one, how do you define an optimal index procedure? Because we've seen that durability is superb with that self-expanding supra-annular platform. Aerodynamics, it's good. But how do we make sure that we obtain the best out of the device at the index procedure? What is the list of the items?
Yeah, so first of all, in terms of sizing, in this particular patient, I would agree with the larger size.
34?
Because I'm not so impressed with the amount of calcium, and I assume that this device will handle the calcium properly. Also, a larger device equals hopefully also a larger gradient, a larger area after the implant and lower gradient. So that is definitely what I want to achieve. Then in terms of optimal results, obviously I don't want to have PVL, and I want to minimize the risk for conduction issues. And at the same time, I want to be able to re-access coronary. So it starts with the introduction of the system. You want to have this with the flush port at 3 o'clock, and then you want to make sure that you have commissural alignment. Now with the new features, with these gold markers, it becomes easier to appreciate commissural alignment. So that is, I think, very important. And then in terms of the implant depth, also these gold markers will help us with the interpretation of the depth, but I would always rely on 3 projections. I used to be very eminent in using only the coplanar view, but also with the work of Gilbert and others, and Ola was also very instrumental into the use of and the implementation of cusp overlap. And then I added a 3rd view, that is a simple LAO view, sometimes a little bit steeper LAO, in order to really appreciate the depth at all the 3 cusps levels. That's basically my approach.
So thank you. That's a nice summary. So one could expect even more reproducible procedures with this device. So let's join Tiffany and Simon in London. They should be ready for the strategy, describing their strategy and treating the patient. Hi, Simon. We see you. Hi, Tiffany. So we see you nicely on screen. Do you hear us?
Hi.
Okay.
Welcome back again. So yeah, I'm Simon Redwood on my left doing this case. We do hear you very well.
Excellent.
So on my left is Tiffany, who will be doing the case, and just behind Tiffany you can see Seb Baxter, who's our anaesthetist, doing the case, and we've got our scrub nurse is Lucia. Can we put the strategy slides up, please? So I'll just tell you briefly about the strategy, and then we'll show you where we are. So next slide. So the aim of this case is to show you a step-by-step deployment of the Evolut FX and to demonstrate some of the features that you've just been talking through, the deliverability, which should be and is a lot easier, the ease of commissural alignment, and stability during deployments. Next slide. So we have bifemoral access. That's already been done, ultrasound-guided, micropuncture on both sides. We've pre-closed the right side with a single ProGlide. We've introduced a 16 French gore dry seal, and our plan is to cross the valve, do a balloon valvuloplasty with a 22 millimeter balloon, and then deploy an Evolut FX 34 millimeter valve. Next. And I mentioned briefly some of the people in here. Lucia's our scrub nurse, Jessica's our running nurse. We've got Seb Baxter, David's our radiographer, and Sassy is the medical coordinator. So if we could go back to live. So you can see, I don't know if you can see the table there, but we've got bifemoral access, 6 French on the left side, the gore dry seal on the right side. We've got an AL1 up there, and we're just about to cross the valve.
Should we show our aortograms quickly? Staging aortograms. So cusp overlap will show you which was an eleocranial.
This is this PA caudal is our cusp overlap. And
coplanar, yeah. So eleocranial was our coplanar view. And then the one after that, the PA caudal for our cusp overlap. And we checked the valve just beforehand as well.
These are very nice views, so they are going to be extremely helpful.
Are you happy for us to keep going? Any other comments?
Yeah. While you are advancing and about to cross the aortic valve, Tiffany, there is one consideration that I have in mind. We are always talking about improving the outcomes for the patient, and we have these cerebral protection devices. We are still struggling trying to identify who could be a good candidate for that. So the question to you, Tiffany and Simon, is what is the profile of the patient for whom you would consider a cerebral protection device? Is it this type of calcified patient? Is it based on the age? Or is it only the financial consideration, the reimbursement issue?
And that's a very good question, and we don't really know the answer. I mean, finance is obviously a problem, particularly in the UK and the NHS system. At present, we don't know, but we think we will use cerebral protection in patients who have had previous strokes, previous TIAs, extensive calcification of the ascending and arch of the aorta, and extensive calcification of the valve. Other than that, we don't use it routinely, and we usually put patients into the PROTECT BHF trial. So we've actually decided not to use cerebral protection here. He's got no significant past history that we think would increase his risk. And the ascending and arch don't look particularly calcified.
But we did try to enroll him in BHF PROTECT.
We did, and didn't succeed.
Okay. So thank you for that. Maybe we can have, while you are exchanging for a picture before the stiff wire, the curved wire, maybe we can have a panel, the view from the panel about that. Cerebral protection systematically, or is there a specific group of patients for whom you would utilize that? Nico?
Yeah, I would go for systematic. And why? Because we know that we will capture debris in all the patients. We just don't know what kind of damage these particles will create, and will they be early? Will it be early damage, or it may also be later damage? So I would, if it's anatomically feasible, I do it in all my cases.
You have the same perception, Tanya?
So we just do it in selected patients who had previous stroke or TIA. I think with the data we have so far, I think we cannot really, I'm not convinced that we have to use it in every patient. And I think the other problem is that we also have patients who develop a stroke after the procedure. I think this is another problem, that a protection device does not really help in this kind of patient set.
So for you, it would be a past history of stroke neurological events. Michael, do you have another view on that?
Well, so my senior cardiologist is very data-driven. He doesn't want to use it in anybody because there's no data. My mid-level guy wants to use it in everybody, and my fellows want to do it. So we do it in about half the patients. We make up some cases we want to do it in, but we're just making it up. Bicuspid valves, heavily calcified, previous stroke. But there's no data. That's just how we feel.
Okay. So let me come back to you guys in St. Thomas's. So we see the wire within the left ventricle. We've learned with the past iteration of the device how important it was to select the proper wire, to get the wire on the external curvature, to get a nice support and coaxiality. Which wire are you using for this case? Is it a Safari small, Safari extra small? Is it? Do you advocate a Lunderquist? Which wire is that, Tiffany?
This is a Safari small.
Yeah, small Safari. Sorry, go ahead.
I was going to say it's perhaps a bit less important with the FX to have it hugging the outside of the aorta. It's a lot more stable, the deployment, which hopefully we'll show you in a minute.
But if, say, for example, there was a lot of tortuosity in the legs, we still would go for a Lundquist. It does help in those situations as well. If there was heavy calcification, a lot of tortuosity.
Do you have the same experience, Gilbert, as you have been using the FX for a long time? Is the wire important, or do you use any kind of wire for the FX? Gilbert?
Yeah, so I would say that based on our data, the Lundquist is not necessary for Evolut FX. In fact, a majority of our wire choice actually, Homo 100 prints is Safari, but we use extra small because we have just more friendly in terms of smaller women, in terms of the ventricles.
Okay. So Simon, let me go back to you. You are about to do the BAV, so maybe you can proceed and then describe your setup for the direct wire pacing and elaborate a bit on the diameter of the balloon that you've used for this calcified valve.
And deflate. I think we had loss of capture. Let's just make sure we get a decent inflation. Just stop pacing there. So what we'll try and do is we lost capture. It might have been because the wire wasn't deep enough. That's actually because this connection was loose. Okay, we'll try again.
We're just going to try and do that again because we lost capture and didn't get a full inflation.
What balloon size is that?
Okay,
what is the size
pacing
of the balloon?
on there, 210.
22.
Okay, that's nice.
22 millimeter VAX2 balloons. It's 22 by 40.
Okay. Pacing off there, please.
22.
Capture that. We'll just check the rhythm. And that's come back.
22.
22, yeah. I think the minimum diameter was 23.6, was it?
And Simon, do you have venous access just in case you think you would need a temporary wire? Or
the hemodynamics are recovered well. We don't. So we'll be pacing on the wire, and we will check that we've got sinus rhythm back before we take the wire out of the ventricle. And if we haven't, we will then put a venous line in then.
And obviously, we usually, or we actually,
so we're just removing the core
predilate
right sheath
when we're using the big valve, the 34 millimeter valve. How do you decide on balloon size? Like, is it based on the small annular diameter? Is it based on your feeling for the anatomy?
It is.
We tend to, don't we? Yeah, we tend to go
We tend to go just below the small annulus diameter, the smaller annulus diameter.
Okay.
Just show you very briefly, you can see the table. I don't know how well it projects, but the nose cone, the taper is much longer. It's a much more gentler taper, and that makes it easier to access the femoral artery. And the other thing that you saw yesterday is that this is a lot more flexible. So if you can see the shaft, you can see here it's a lot more flexible than the previous device.
Okay.
And it means getting up the iliofemoral is a lot easier.
So for procedural alignment, we'll keep our flush ports at 3 o'clock. And wires out on that side, and I'll just try and gently introduce into the legs.
So as this is quite new for the vast majority of us in the audience, we're going to follow your step-by-step description of what you are doing, particularly trying to align for commissural alignment.
So my earpiece just dropped out. But I'll just keep advancing this.
Thoroughly watch what you're doing.
We're going to explain that in just a second. So we've managed to get the device in up to the tip of the inline sheath.
So sorry, I can't hear anything. My earpiece dropped out.
Other way.
Okay, fantastic. I won't do too many head movements, sorry. Okay. Sorry, what was the question?
So about just showing the commissary alignment. So to start with, when we introduce the device,
off mag there so we can see everything.
At 3 o'clock. So the flush port's at 3 o'clock.
Okay, and open up the cones.
In an LAO projection, we'll just check that the hat marker's on the outer curve.
Let's go LAO 30 off the cranial. And open the cones fully. Open the cones fully. Okay. All right. So that's 3 o'clock.
So that's 3 o'clock.
That looks nice.
And I hope you can see there that the marker is on the lateral surface, so just to the right-hand side of the wire port.
Okay, so what we'll do now is we'll put the wire just to the bottom right of the screen so we can see it going around the arch, yeah?
And you can also see the 3 markers, I hope. The 3 markers on the device, which become a lot more evident once we started deploying it.
So just a little bit of traction on the wire here, because there's some calcium just on the arch.
The other important thing to say is not to torque the device in the ascending aorta if you need to change the orientation of it, to do that in the descending aorta.
And we can see the hat marker remains on the outer curve as we come up to the valve.
And if it didn't remain on the outer curve, then we would come back to the descending aorta, reorientate it, and then come back again.
So let's go to the PA caudal view. Yeah.
So we're going to start our deployment in the cusp overlap view, which is what we're going to now. Just center up on the valve. That's it.
So we saw that first check in the descending thoracic aorta with the heart marker in the external curvature, and that should relate to the cusp overlap projection. And it's a little bit new because in the cusp overlap projection, usually with the Pro Plus, we want to see the heart marker center front fully, and with that new FX, it's close to be a near center front aspect of the heart marker. So it's what we have now. Is it the cusp overlap projection, the one that you've decided?
Clearly now that we're at the base of the pigtail. That's another difference. This is yes, it is.
Just go a little bit more caudal.
Yeah, that's exactly what I wanted to discuss with you, and
that's good.
maybe Mike or Gilbert.
Well, it looks like the hat marker is still on the outside, so it looks like you're still not in an overlap yet, because that hat marker should come in front if you overlap.
But do you adjust on the marker to get it perpendicular, or do you accept that kind of near trade-off?
It's not. Yeah.
It's close to be.
I think
it should be right in front.
You do have a dot on the right side of the screen, so I think I would just wait to see. Like you said, Didier, you don't always have the hat mark in the front. If you want, you can certainly bring it back to the descending and maybe rotate a little bit. But
you're pretty AP right now.
Yeah,
one of the things you're trying to do is get RAO to strengthen out the LVOT. So it looks like you need to go a little RAO and a little caudal.
We are.
They are, it seems.
So we can do that. We can go another 5 degrees, 10 degrees RAO and a bit more caudal.
So you start a little bit deeper than the regular cusp overlap technique, into which we advocate to start at the top of the pigtail or the mid pigtail. Here it's more about the bottom part of the pigtail. Let's imagine that you need to adjust. Where are you going to adjust a little bit for a better commissural alignment? Are you going to do it here, or where are you going to do it?
You need to bring it back to the descending aorta, the
descending
aorta, to be able to. And the FX system is very nice.
No, we would go back to the descending aorta.
Yeah. And how much do you rotate? Is it a half rotation, quarter, more?
Are you feeling strongly, or are you happy for us to?
You need to figure out how badly you want to adjust this. You don't have to have commissural alignment.
Yeah, I think we can proceed. I would proceed.
Yeah, I'd proceed.
Yeah, it looks good.
Yeah, it looks good. It's large here also.
Yeah, the aorta is large. You're going to have good access to the coronaries no matter how you do it.
I was thinking that too. Let's go ahead. So we're probably going to pace a little bit there.
Yeah, we tend to always pace at 140. 180 makes you feel dead. 140 makes you feel like you're in love. 140 is fine to pace at.
Again, Gilbert, are you paying attention at this time point to these tiny markers, or are you still focusing on the hat marker, or both?
Here you're just deploying your valve. You don't look at your 3 markers right now.
Yeah, that's for depth. So
just for depth. Yeah, not for orientation.
Very helpful when you do your injection right to the pigtail. What your target implant depth would be, and as it flowers, So my rule of thumb has been if you have 2 of the 3 dots at or below the annulus, you're fine.
Yeah.
But if you have 2 of 3 dots above the annulus, then you're too high, too aortic.
Slightly deeper, I think, here.
Maybe for the audience,
I'd like
it's
to go a
3
bit
millimeter.
deeper, yeah.
3 millimeters
Carry
on the
on.
dots.
We'll go a little
And
bit.
here the pigtail's moved up a little bit, so don't be led astray.
Exactly.
Yeah, it's actually a very good depth.
It has.
Yeah. It's expanding nicely. Okay, that's jumped up a little bit. I think actually it's jumped up, might have come up above the left coronary cusp. Let's go check that in. Well, should we go to the rumble and then we'll go check that in LAO?
Over LAO.
We'll open the valve.
Yeah, just go to 2/3 and
So
cover.
this is the point, actually, it's very important. Sorry, Simon,
open.
Tiffany, I'm going
Have
to
a
bring
little
this
bit
to the
more.
audience attention.
Okay.
You can see
Let's
2
go
of the
to
3
LAO,
dots are
please.
below the annulus as the flowers. So
LAO,
that means it's
please.
not too aortic, number 1. And number 2, you can see that the dots in relationship to this cusp overlap, 1 is on the right side of the screen. So that means that you likely will have good commissure alignment. So I think that,
little bit
it was the
forward.
right decision.
The
not
other thing to
have
look at,
adjust
Gilbert,
it.
is look at that non, see how it comes straight down? If it curves in like a tulip, you're too high. It's going to pop out. If it
Yeah.
comes straight down, you're probably okay.
The beautiful part about the FX is the dots. How do you take the parallax out? Just line up the 3 dots. You don't have to look at anything else. And once you look at line of the 3 dots, Simon, Tiffany, that's how you know there's no parallax on the valve. So you can see here, if the injection, you see there is still a little parallax there because the dots are not aligned. So that's how we can easily see that. And this is actually especially valuable for valve-in-valve.
Yeah. But you get a more
Thank you,
symmetrical
guys.
implant.
Just let's come back to the team. What is your perception
bit more caudal.
of the depth, Simon and Tiffany, in the free cusp planar view and the cusp overlap projection? Because as it is new, what could be interesting for all of us here to see the location
I
of the
think-
marker.
Perfect.
Second, and the depth.
We're just trying to. Yeah.
So you're still pacing at that stage.
So we're at a LAO caudal view now. We're trying to find a view where we're seeing the 3 markers in line. We are still pacing,
Yeah.
and the hemodynamics are fine.
And would you do the cusp overlap projection, cusp overlap
Over
view,
this,
so as
actually.
to we can assess the depth in the non-coronary sinus? Because it seems good.
It looks very symmetrical.
Yeah.
Yeah, we did. We can do one more quickly, and so you can see. So let's go to the.
Everything is stable, so we're in
Yeah.
no rush.
So let's go to
Cusp
an
overlap
REO
view.
caudal. We'll do an REO caudal because that was a bit, yeah.
I'm good.
And over to the PA caudal. So let's see if we've got too much REO there. That's it there. Stop. Okay, I think that's a better appreciation there, isn't it? So back over to that LEO caudal we had.
Appreciate is that you have a more symmetrical implant.
Are you happy
depth
with
on
the
both
depth?
sides. So, which is great. I
Yeah.
think.
Yeah, here we'd pull our wire back, wait a few minutes, let it warm up, then just deploy it.
So it looks really nice from what we
Seem a
saw.
little bit higher on the.
Yeah.
So you need to combine both views, the real free cusp planar view and the real cusp overlap projection.
We'll
Otherwise,
want to
it's
inject
a bit
soon. We're
difficult
going to
to
move
analyze
the
the
pigtail
depth.
back in
Yeah.
a second.
What are your thoughts, Didier?
So let's. So could you replay the cusp overlap projection? It's going to help us understand what is the depth in the non-coronary sinus.
Should we pull the pigtail back in the
I think you required that before.
Yeah, just go back one picture. Don't move the table. Don't move the II.
Here,
There.
it looks great. So the depth here is really
Yeah,
nice.
This
that's
one,
it.
we just did it.
Let that play.
And even well, we have one marker that is facing or near to
And
the
then go
commissure between
forward
the
one.
left and the right.
And now we're in the LAO caudal.
And the true
And
free
again.
cusp planar projection. That's why it's really difficult when you align on the stand frame because you lose the location of the annulus. So the reference should always be the annulus, otherwise it's a little bit tricky. But here it looks okay. Happy?
Yeah.
Pigtail.
Cool.
Yeah.
I would just
So
do
what
another
I- yeah?
injection here
I
just to
think
be
we're
sure.
happy. Are you happy?
Yeah, I would just do one more injection here with the 3 dots lined up because
Yeah,
it looked like the valve might have moved up a little bit. based on at least
yeah, it seems that it's not exactly the same projection. But what they do to remove the wire, and it's the FX, and we can see how coaxial it is already at before the release of the outflow. The idea is to push a little bit less than we do usually. And what could be interesting when you have such high implants is to expand the outflow very slowly. Some pace. Do you pace, Mohamed, at that
Yes.
at that time?
Yes.
You may pace depending on what is your policy.
Both off.
But the speed is very important to expand very slowly the outflow.
Yeah. So I do pace. I sometimes find it difficult because if you're doing wire pacing and you want to pull the wire a little bit during final release, so then pacing maybe not perfect.
Yep.
But I do want to pace while releasing the valve, particularly if we're implanting it in a shallow position. But it seems it worked here nicely. I mean, pacing is still happening despite the fact that the wire is almost in the nose cone.
So that's a nice demonstration.
Yeah.
Direct wire pacing works as soon as you have contact, as long as you have contact with the left ventricular wire. So it could be the apex or it could be mid cavity. It works. The very tricky situations are post myocardial infarction. So if you have scar, it's going to be a little bit. It's going to be more difficult.
But you can't stop pacing now. There is no point. Huh?
Yeah. So I guess the team, that's what they did.
We have 7 minutes left.
Okay, so we have kind of 3 minutes left, Tiffany and Simon. So we will let you work to see the final angiogram. That is going to be
Okay, great.
great.
So we just
That's
take
what
the
we
gore
expect.
back. What's the end of the wire?
And would you
Feed the
do
wire
it
a
in
little
the, if you
And
could
we'll
do
take
it in the
overlap.
cusp
Of
of a
course.
lab projection, that
Gore
final
and pixel,
angiogram,
please.
to assess everything, the depth, the location of the markers, the commissural alignment, that would be
Of course,
awesome.
yeah.
Here from the aortic wave, we can see that regurgitation shouldn't be an issue here.
Can we get a second line?
But I think it's great to see how slowly they released the valve. This is actually how you should be doing it. So
Yeah.
We don't have a second
it helps you stabilize the valve during final release, and the valve didn't move.
Just the line.
The line for that.
And Gilbert, so while they're preparing for the final angiogram, you've shown during the imaging analysis the membranous septum. I'm still struggling to understand how to integrate that into my algorithm for valve selection, depth of implant. Well,
So-
do you have a cutoff? What do you do?
No, it's not so much a cutoff, it's all relative, right? So if your membranous septum is 10, you can afford to be, 5 and 6, and should be okay. But if it's only 2 or 3, and actually it's very common in bicuspids, as you know, that's why bicuspid is high pacemaker, you might want to aim higher, but of course you don't want to pop out. So it's a little bit of balance, and so when we teach our fellows, we say just watch that in terms of initial. And the beautiful part about FX is very more symmetric, so you can afford to be able to be more predictable in your target depth to start with. So that's kind of how we actually use that to our advantage. And of course, Angela has published a paper on that in terms of septal length measurement does impact on your risk of pacemakers, even in the context of right bundle.
Thank you for that, for this comment.
Some air in here.
So it was really nice to see that the new features of the device were really implemented through this challenging case because of calcium, because of the large dimension of the annulus, and overall you could achieve a nice orientation with the heart marker to get commissural alignment, and it was quite stable. And I like the way you paced. One could discuss the duration of the pacing, but overall the idea of pacing during the deployment makes sense because you're going to get an additional increased stability particularly for the outflow.
Tiny bit of air.
With a wire. I mean, exactly.
Should we take it out?
So hemodynamics look perfect as we were used to.
So I just pulled it out, but we had no gradient. I'm just going to take another picture.
A little bit of AR.
Tiny bit of AR, but we knew there was 2 nodules of calcium. Trace. And we're happy with the depth. There's no... How's the rhythm doing?
Do you want to do a coplanar view then?
Yeah, let's do a LAO.
PA caudal.
Would you do something
No, I thought we were
else?
doing...
Would you post dilate in this case?
Yeah.
Ore? No?
Yeah, that's perfect.
Mike?
Yeah, we likely would. You've got plenty of room there that's down at 4 millimeters. It's very safe to dilate this valve.
Come off caudal, actually.
We've kind of gotten where any AR bothers us, you know, and you've got room to play with this.
Caudal.
There's not so much calcium that I'm worried you're going to hurt anything. And if you want to be safe, use a 25 balloon. If you want to be definitive on 34, use a 26.
That's good.
Yeah, I would, in this not too nodular calcium part, use a 25 true balloon. Also, always look at the echo first. If the echo doesn't show any significant PVL, I mean, even trivial, I would accept it because, you know, there is a downside of pacing again and recrossing and post-dilate, so.
And the question for you, Tanya, is this is a self-expanding platform, so the recommendation usually is to wait like 10 minutes before deciding on post-dilatation or not. Do you wait or do you go directly for post-dil when you think that it's required?
I think we wait a little bit. So we first assess PVL by echo.
Echo?
So transthoracic echo, and then we do the angio. So usually this takes 3 to 4 minutes. I think 10 might be a little bit long, but I think 3 to 5 minutes are reasonable.
I mean, if it's clearly high, mild, or moderate, you don't wait. You just do it. But if it's something tiny like this, you just wait and watch it.
Tiffany and Simon, so what's your evaluation of the outcome for the patient? What are you going to do? Are you happy? It seems to be the depth is superb. Hemodynamics is great. There is no conduction disturbance, high degree conduction disturbance, LBBB, but nothing greater than that. You seem to be happy, as we are.
Well, we're very pleased, actually.
I mean, it's a balance between, you know, tiny bit of regurg and annular rupture.
And as you say, in a few minutes' time or later on this afternoon, it'll be a lot better. And those nodules of calcium are quite aggressive. So I think we've got a good result, very nice result, actually. So probably best left as is.
Okay, so I think you deserve a big round of applause because it was a beautiful demonstration.
How do you play with these markers? Like, what's your take for that? So, are they more for the depth, more for commissural alignment, for both?
I think we'll use it to help us with commissural alignment, as we were discussing during the case. I have the impression that it also gives me a better appreciation of the implant depth, though. Yeah, and you know, it's always an interpretation on a case-by-case level. If a patient is unstable, you don't bother too much about double-checking commissural alignment. If the patient is very young, completely stable in the procedure, then you really take your time, because if you want to correct your alignment, you really have to resheath, completely take out the valve to the descending aorta, and then make your correcting maneuver. So that takes time, and in an unstable patient, I wouldn't bother too much. So in principle, I feel that these gold markers will be very helpful in the appreciation of the implant depth. And as an add-on, it's also helpful with commissural alignment. But I think based on the work of Gilbert and others, we are already quite effective in commissural alignment without the gold markers.
So let me ask Gilbert maybe to show us a little bit or summarize the experience you have so far in the United States with the Evolut FX. I think the European experience is still limited, and you did a lot more cases in the United States so far.
So yeah, you know, we have started using Evolut FX since the limited market release in the United States last June, actually, and this is the first multi-center paper that was published in JACC Prevention recently. You can see that this is the early limited market release experience of 226 patients in the U.S. centers. You can see the average age around 80 here. About a third of them are low surgical risk, 4% bicuspid, and actually 10% were valve-in-valve. And most are done with conscious sedation. And you can see Lundekreuz stiff wire was only used in about a third of the cases, and about 2/3 are using direct inline sheath. And with this kind of early experience, we already get about 98% of the time with the head marker at the optimal orientation with a 99% technical success. And if, as you saw in a St. Thomas live case, you can see the valve is more symmetric at release. You can see the NCC and LCC were actually only about 1 millimeter apart. And in terms of commissural alignment, you can get about 96.5% perfect alignment or just mild misalignment, which should have no consequence in terms of reaccess or lifetime management. You also can see that it's very low early 30-day mortality, stroke, vascular complication, pacemaker rate, and also paravalvular leak, with only one person actually have moderate in this series. Now, we actually at Mount Sinai compare our own series compared to Pro Plus. You can see this is the time period. And of course, with the Evolut FX, it doesn't increase your head mark orientation that much, but certainly commissural alignment, at least with 0 to 30 degrees off, would be actually much higher than Pro Plus. And as you've seen earlier as well, the left cusp actually definitely a little bit higher than the Pro Plus in terms of symmetry. And finally, you can also see that there's fewer recapturing just because you're at a more optimal depth. Now, I want to show you now, this is actually the entire United States. This was presented at TVT with Dr. Wawa Tong and on behalf of the investigators. And this is 1,700 Evolut FX now across 700 centers versus 4,000 patients with Pro Plus. And you can see that here there were statistically less major life-threatening bleeding. There were lower percentage of device recapture procedure. Procedure time is also a few minutes faster, and also no difference in terms of length of stay as well. So I think in summary, in terms of Evolut FX compared to Pro Plus, clearly there's an advancement in the technology and technique in terms of deployment, procedural time, repositioning, bleeding has all been improved. Moderate severe PVL is really just rare to speak of now with FX. Higher rate of device success, fewer recapture, and both groups, I would say, are comparable in terms of the pacemaker rate, valve intervention, and any clinical outcomes. And of course, just like any other Evolut platform, the hemodynamics have been excellent. Thank you.
Start with the pacemaker.
Yes, so, I mean, it's good to see that these changes that have been made, that they do work. There are a few questions coming from the participants here, like not specifically on the FX, but on some of the aspects of the procedure. So there's one question regarding balloon aortic valvuloplasty, criteria for deciding. Tanya, will you want to?
So when do you predilate?
When do you predilate?
So it definitely depends on the load of the calcification. So if it's highly calcified, then I would go for a predilatation. And I would also usually go for a predilatation in bicuspid valves. And the other thing is the gradient, but I think that the load of the calcification counts more than the gradient.
There's also one question regarding access. So a question, why did the team in St. Thomas use bifemoral access? I mean, could be, of course, an option to take the radial artery. What is your practice, Nicola?
My practice is single access site, so I will go for a superficial and common femoral arterial access on one groin.
And how do you close the superficial?
So it's a 5 French system that I close with a perclose.
A perclose.
Yeah, and the reason for doing this is that I preserve my radial for embolic protection, as I am a big believer in that. And it's easier to confirm your patent hemostasis after your large bore arteriotomy closure. And from a patient perspective, ambulation is a little bit easier when you only got access in one groin as compared to 2 groins.
Ole, you just published the multi-close registry. Can you tell us a little bit about that? Because I think this is also an interesting concept.
Yeah, that's true. That was work done by some fellows in our center, and we developed in a way an algorithm to say, okay, how to get rid of that complexity for checking your closure. I don't like people doing from a radial check. It's sometimes a lot of radiation and difficult to get down. And if you're down and you see a problem, then you can't do anything anyway. Contralateral, yeah, you have to sacrifice another groin. So the approach is more that when you take out the introducer sheet, whatever size it is, 14, 16, 18 French, you take it out. We keep. You can keep any wire, but the stiff wire we keep in typically. We close our single ProGlide now. Typically, it's a single ProGlide. We close our single ProGlide. And at the same time, when the large sheet is taken out, we introduce an 8 French sheet again. And we close actually around that 8 French sheet, our ProGlide. multiple advantages. I think you really are sure that you have touch on the sheet. Sometimes, especially in obese patients, it's not always easy to be sure you're really pushing the knot all the way down to the artery. And then you take your dilator out from the 8 French sheet and you take a small angiography, just 4-5 cc of contrast through the arteriotomy where you did your Tavi from, in a small angulation, so you open up nicely the bifurcation. And then, in fact, that gives you that's why we call it multi-close. It gives you a range of options. So if you see around the 8 French sheet, there's no bleeding, but it's like a big vessel like this one, for sure we would close with an 8 French angioceal and close off like that. That's in 85-90% of cases like that. Let's say there's a very minor oozing beside the sheet. We know that just an angioceal around that, on top of that, is going to be enough. If we see some moderate oozing around it, that's the moment where we then use occasionally a second ProGlide or a ProStyle. So you can taper really your needs, and if you really have a catastrophe in your closure with your ProGlide, on that moment, there's some tricks to get to close it then with a Manta bailout, as we do. So we have a series, indeed, your intervention. Can recommend to read it. Mm-hmm. And I think it's super easy because it's super quick. Yes, it's extremely easy to do it. You save time, literally a couple of minutes per case, and you can have that tapered choice of options what you need, like nothing, angioceal, an extra ProGlide, and maybe angioceal or the Manta. That gives you, and like that we push our major vascular complication rate below 1%, and it's in multi-center. Yeah.
Definitely a very interesting approach, and I really recommend you to read the paper.
And how do you do it?
Mentioned to avoid the hassle of going down with the pigtail and do the angiogram, and it's a very elegant approach, to be honest, and it works. Yeah, it works.
So it's all about that discussion brings us back to making sure that at the index procedure we get the best outcomes for the patient. And it starts with the vascular complications. We've seen that with that self-expanding supra-annular platform, we could achieve very nice hemodynamics. We knew that from the past. Very good durability. We've got that from the Notion and now the 4 years low-risk data. There was one question coming from the audience. The Evolut FX may have an impact on that. We have to see. It was about pacemaker, because we have to accept that in the past, the pacemaker rate was one of the disadvantages of that self-expanding platform. What is your contemporary experience, Gilbert and Mike, in terms of pacemaker rate with the implementation of the cusp overlap technique, the new Evolut FX that really controls the depth of implant? What is your pacemaker rate now today?
So for us, it's well less than 10%. I think, obviously the white bundle branch block, doesn't matter what valve you put in, it's going to be very high risk for pacemaker, and you don't want to have a pop out or migration implant too high. But in general, normal sinus rhythm, even someone with first degree, we generally have now, 10%, very less than 10%. So very competitive with surgical AVR.
I track mine every quarter. It's 6 to 8%.
6 to 8. Below 10. Below 10.
It's below 10. And even the TVT register, it looks at everybody, it's below 10.
Yeah.
So that's quite reassuring. And so there was a question. Yeah, we have the poll question. And just while you are bringing up the poll question, there was one question about patient's preference. In the live case, they stated that the patient was 76 and was in favor of Tavi. Is it, as a surgeon, Mike, something that you consider? Is it contemporary practice? Do we have to keep this as one of the major part of the discussion, what the patient wants and desires, because we have multiple options. We have equipoise between surgery and Tavi. We can say that at 10 years with that platform at least. What do we do with that patient's preference?
But a 76-year-old has anatomy for TAVR at my place is going to get TAVR every single time. How low do you go? Well, I'm 70. If my anatomy looks like this, you're going to be doing a TAVR in me. I've become very comfortable. As you start getting down to 65 and lower, then it becomes more problematic. And I think the other question you have to ask yourself is, what valves are your surgeons sending back to you? If you have a surgeon that's sending you back 19 and 21 valves, you should probably just get TAVR. If you have a surgeon that's sending you back 25 valves, 27 valves, then that patient's going to do well and be a good landing zone if something goes wrong. So you have to know your surgeon too. What are you getting back?
I think if you go in that age group of 65 to 75, I'm okay doing Tavi on it, but I want to know, before taking a decision on Tavi or surgery, what the anatomy is. I think really that's what we pushed in Copenhagen through, that 3 years ago, everybody, but really everybody, even up to 50 years, if he has an aortic stenosis, he has to be discussed at the heart meeting. Just everybody gets a cardiac CT. And then you can really make a profound, objective discussion at that heart meeting. Otherwise, it's a lot about egos and other things that you're discussing, but actually not the anatomy of the patient. And that's what, because sometimes if you go in that lower age group, we forgot, I mean, we didn't discuss that a lot, but I mean, your rate of bicuspidity goes exponentially up. So I want to know, I'm okay treating a bicuspid patient, but if it's a hostile bicuspid for a Tavi, I'm fair enough to say, okay, this 69-year-old, okay, you know what, even the preference of the patient is Tavi maybe, but let's try to invest and to maybe talk this man over to say, okay, maybe it's wiser for you to go for surgery first. If you, later in your life, you need something else, we will fix it transcatheter based. But I mean, you have to make a good discussion.
We do a CT on everybody I'm planning on even operating on now. I won't do an AVR without a pre-CT because of the data we gain helps me in my surgical planning. If they have a small annulus, I know I'm going to do an annular enlargement. I tell them I plan that into my day. I mean, right now I do annular enlargements about 40% of my patients. It's nice to know going into the OR what you're going to do.
So that's a very important consideration. We should acquire the CT scan for every single aortic stenosis patient and have an honest discussion, including integrating the patient. So that's very interesting because this is what you think is relevant. And what this is the result of the poll. And before, that was at the very start, beginning of the session. And clearly, we can see that for 63% of the ones who responded, durability is the key consideration. So then it's followed by hemodynamics, coronary access, and at last pacemaker. So let me ask just a show hand a question. Did you get what you expected in terms of understanding durability of the Tavi platforms, particularly the self-expanding supra-annular and hemodynamics? Or do you need more information? Did you get clear messages about durability? Raise your hand. Okay, so it's a quite significant number. There is still work to do on that in terms of acquiring knowledge, and we have to wait for the 10 years durability data from both the low risk, Evolut low risk, and the partner-free data. But it seems that we are moving into the right direction, so it's quite reassuring for that. So Mo, we are coming to the end of the session. I think it's the floor is yours.
Yep, maybe we have 1 minute maybe to address coronary access concerns. I mean, 12%, it's not a big percentage, but like, did we settle everything regarding coronary access with the long self-expanding platform when we are doing commercial alignment? Any thoughts about that, Gilbert?
Well, I mean, actually, Guy Adesani from Cleveland just actually recently showed an abstract presented at TCT. Actually, he did an on-table coronary angiography after Evolut FX implant in about 50 patients, and they have to post-CT to look at commercial alignment, and that he has been able to engage coronaries, 100% of them. I mean, at least 60% of them are selective, so certainly it's much easier and when you know. Now, I think the challenge is more in terms of interventional cardiologists who don't do Tavi or not familiar with Tavi devices. And those we still need to educate and train them on how to recognize this and be able to do this. And we have an app, actually. My colleague, Dr. Keeney and Dr. Sharma have actually developed an app to teach people how to do this now. So I think this is certainly not an important issue, but I think there's more to teach others.
Okay. And Nicholas, if this patient needs a redo procedure, is it going to be difficult? Is it going to be easy when we consider his anatomy? Is he going to need a redo procedure at all with a 34mm valve?
I don't think so. I think this patient will do well, and the valve will outlive the patient or may outlive the patient. But if needed, I don't foresee any issues with a revalving procedure. And these days, we're also exploring the value of a simulation device, procedure simulation, where you can actually determine which would be the best fit, which design would fit best in a failing, for instance, Evolut valve, and then look at how this valve-in-valve construction will relate to the coronaries, also in terms of the development of a neoskirt and all those kind of aspects. So we're getting better and better in completely understanding what are the lifetime options for each patient from the get-go.
Great. So great summary words. So I think we've seen in this session, also through this
see the slide,
very elegantly performed live case from St. Thomas, probably that with this platform, valve durability probably has the potential to cover the lifespan of a big percentage of patients. And with the early experience we now have with the FX in the United States and now in Europe as well, I think you can see that we have some improvements, some important improvements regarding ease of use compared to the Pro Plus system. It has better trackability, repositioning, recapturing probably will be less, and we've seen this in the data presented by Gilbert. For me, I think symmetric deployment is an advantage of this platform, and it does help you to get this valve in a more coaxial position, and it has also the potential to improve commissural alignment. That being said, the case we've seen today was a more or less straightforward anatomy. It had some challenges regarding LVOT calcification, but it was a more or less straightforward anatomy. So if you're interested to see how this platform is also performing in more complex cases, I want to refer to a session today at 5:30 using the FX in complex anatomical scenarios. So thank you for being here. Thank you for Medtronic for hosting this session, and I hope you enjoy the rest of your day.
Thank you, Josh.